Welcome to the second part of this lecture series on National Tobacco Control Program Guidelines for Training of Doctors. In this session, we will discuss the prevention and control of tobacco use along with evidence-based pharmacotherapy options used in tobacco cessation management. Introduction to Prevention and Control of Tobacco Use. Tobacco use may be seen as an act to cover insecurity or as a way to appear grown-up and sophisticated. Common reasons for tobacco use includes addiction and dependence, influence from friends and surroundings, curiosity, stress relief, and lack of proper cessation support. Understanding tobacco addiction. Addiction is a state of physical and psychological dependence. Nicotine is the addictive substance present in tobacco. It stimulates the reward pathways in brain and creates temporary pleasure. Continued use leads to craving and dependence, and withdrawal symptoms during quitting make tobacco addiction difficult to overcome. Primary prevention aims to prevent the initiation of tobacco use through health education, awareness programs, and tobacco control policies. Secondary prevention focuses on early diagnosis and screening of tobacco-related diseases, and tertiary prevention aims to reduce complications, disability, and improvement of quality of life through rehabilitation and supportive care. What is cold turkey? Cold turkey refers to sudden and complete stopping of tobacco use without gradual reduction or nicotine replacement therapy. This method can be difficult because withdrawal symptoms such as craving, irritability, and anxiety and restlessness are common. Behavioral counseling for tobacco cessation. The 5 A's approach is commonly used in tobacco cessation counseling. Ask every patient about tobacco use. Advise all tobacco users to quit. Assess the willingness to quit and make a quit attempt. Assist the patient in developing a quit plan. Arrange follow-up visit and support to prevent relapse. 5 R's for unwilling patient. For patients who are not ready to quit, the 5 R's approach is used for motivation. Relevance means discussing person importance of quitting. Risk refer to explaining harmful effect of tobacco. Rewards highlight the benefit of quitting. Roadblocks identify barriers for cessation. Repetition means reinforcing counseling during every visit. This flowchart explains the intervention method algorithm for quitting tobacco use in a clinical setting. The process starts when patient present to healthcare provider. The first and important step is to ask whether patient currently uses tobacco. This helps identify tobacco users early during every healthcare visit. If the answer is yes, healthcare provider should advise the patient clearly and strongly to quit tobacco use. Next step is to assess whether patient is ready to quit. If patient is ready to quit, we move to assist. This includes providing appropriate treatment such as behavioral counseling, nicotine replacement therapy, and medications for tobacco cessation. After initiating treatment, arrange follow-up visit to monitor progress, reinforce motivation, and prevent relapse. If patient is not ready to quit, goal is to promote motivation to quit using 5 R's approach. Relevance, risk, rewards, roadblock, and repetition. If the patient does not currently use tobacco, the healthcare provider should assess whether patient previously used tobacco. If a patient is a former tobacco user, praise them for quitting and focus on preventing relapse. If patient has never used tobacco, praise and educate patient and encourage continued abstinence from tobacco use. This algorithm highlights the structured 5 A's approach, which forms the foundation of effective tobacco cessation counseling. Quitting tobacco produces health benefit almost immediately. Within 20 minutes, blood pressure and pulse rate begin returning to normal. After 8 hours, carbon monoxide levels decrease and oxygen levels improve. By 24 hours, the risk of heart attack already starts declining. In 48 hours, nerve endings begin recovering and senses of smell and taste improve. Between 2 weeks and 3 months, circulation and lung function improve significantly, making physical activity easier. Over the next several months, coughing, tiredness and shortness of breath reduce as lungs begin clearing mucus more effectively. At 1 year, risk of coronary artery disease falls to nearly half that of smoker. By 5 years, stroke risk approaches to that of non-smoker and risk of several cancers declines substantially. Tobacco cessation counseling should be practical and patient-centered. Encourage patients to commit to a tobacco-free life and help them set a clear quit date. Patients should inform family and friends about their decision so that they can receive emotional support. It is important to identify common triggers such as stress, social situations, or withdrawal symptoms and plan strategies to handle them effectively. Advise the patient to remove tobacco products, ashtrays, and lighters from their surroundings and avoid environments where others smoke. Healthcare professionals should also discuss counseling options and pharmacotherapy whenever appropriate to improve quit success rate. Role of healthcare providers. Healthcare providers play a critical role in tobacco cessation. Every patient visit should include assessment of tobacco use status and brief counseling advice. Documentation is equally important. Tobacco use history, counseling provided, and follow-up plans should be recorded during each visit. Consistent reinforcement from healthcare professionals significantly improve the chances of successful quitting and long-term abstinence. When a person stops using tobacco, body reacts to absence of nicotine. This leads to nicotine withdrawal symptoms. The most common symptom is strong craving for tobacco. Patient may also experience anxiety, nervousness, restlessness, headache, and irritability. Many people find it difficult to concentrate or think clearly during this phase. Some may develop low mood, tiredness, insomnia, and increased appetite, which can eventually lead to weight gain. It is important to understand that not everyone experiences the same symptoms and severity also differs from person to person. How to deal with nicotine withdrawal symptoms. The first few days after quitting tobacco are the most difficult. Patients usually need maximum support during first 3 days and first 3 weeks after stopping tobacco use. Cravings are the strongest during this time. But an important point to remember is that craving attack usually lasts less than 3 minutes, even though they may feel much longer to the patient. Simple measures can help patient manage withdrawal symptoms. Chewing anise seeds or sonaf, practicing deep breathing exercises, taking short walks, and drinking water are all useful strategies. Continuous encouragement and support from healthcare workers and family members play a major role in successful quitting. Pharmacotherapy plays an important role in helping tobacco users quit successfully. These medications reduce craving and withdrawal symptoms, making quitting process easier and more manageable. First major treatment option developed for smoking cessation was nicotine replacement therapy, also known as NRT. It provides purified nicotine in controlled doses through gum, lozenges, nasal spray, inhalers, or patches. Other medications include antidepressants such as Bupropion and Nortriptyline. Varenicline is a newer medication that acts as a partial agonist at nicotine acetylcholine receptors and has shown higher quit rate in clinical studies. informed consent, and when to prescribe pharmacotherapy. Before starting pharmacotherapy, patients should be properly counseled about the treatment. Healthcare providers must explain the expected benefit of medication, how it reduces cravings and withdrawal symptoms, and possible side effects associated with the treatment. This informed discussion improves patient confidence and treatment adherence and overall success in tobacco cessation. When to prescribe pharmacotherapy? Pharmacotherapy is recommended for severe nicotine dependence, especially when Fagerstrom questionnaire score is more than 6. It is also useful in tobacco users who have made multiple quit attempts or those who are unable to quit with counseling or brief interventions. Certain clinical indicators suggest high nicotine dependence. This includes using tobacco within first 30 minutes after waking up, smoking more than 20 cigarettes or BDs per day, or consuming large amount of smokeless tobacco. Identifying these patients early help healthcare providers choose appropriate treatment strategies and improve the quit success rate. This slide highlights screening for tobacco dependence using standardized assessment tool. For smoking tobacco users, the Fagerstrom test for nicotine dependence is used, while for smokeless tobacco users, modified Fagerstrom test is applied. These questionnaires assess factors such as time to first tobacco use after waking, frequency of use, difficulty in avoiding tobacco, and dependence severity. Based on total score, dependence can be categorized from low to high, which helps clinicians plan appropriate counseling and pharmacotherapy for tobacco cessation. Now let's discuss pharmacotherapy option used for tobacco cessation. These treatments are broadly divided into nicotine replacement therapy or non-nicotine replacement medications. Nicotine gum. Nicotine gum is commonly used in smokers with mild to moderate nicotine dependence. For patients smoking 1 to 24 cigarettes or BDs per day, 2 mg is prescribed up to 24 pieces daily for about 12 weeks. For heavier smokers more than 25 cigarettes or BDs per day, 4 mg is preferred, again up to 24 pieces per daily for 12 weeks. Chewers generally require 1/4 to half of prescribed dose used for smokers. Common side effects include mouth soreness, throat irritation, dyspepsia, nausea, vomiting, hiccups, and excessive salivation. Nicotine gum should be avoided in patients with active gastric ulcers, recent myocardial infarction, or stroke within past 2 weeks, and poorly controlled cardiovascular disease. Nicotine patches provide continuous nicotine delivery through skin. Usual regimen starts with 21 mg patch for 4 weeks, followed by 15 mg for 2 weeks, and then 7 mg for another 2 weeks. Common adverse effects are local skin reactions and insomnia. Patches are contraindicated in patients with recent myocardial infarction, stroke, or unstable cardiovascular disease. Nicotine inhalers are another form of replacement therapy. Recommended dose is 6 to 16 cartridges per day up to 6 months. Patient may experience local irritation of mouth and throat. Nasal spray acts rapidly and is useful for strong cravings. Dose is usually 1 to 2 sprays every hour for 3 to 6 months. Side effects include nasal irritation, throat irritation, coughing, and watering of eyes. Among non-nicotine replacement therapies, Bupropion is widely used. Treatment is started while patient is still using tobacco, and the dose begins with 150 mg once daily for first 3 days, followed by 150 mg twice daily for 7 to 12 weeks. Patients are usually advised to stop tobacco completely about 2 weeks after starting Bupropion. Common adverse effects include agitation, insomnia, gastrointestinal upset, anorexia, headache, and reduced seizure threshold at higher doses. Bupropion is contraindicated in patients with seizure disorders, severe liver disease, alcohol or benzodiazepine withdrawal, pregnancy, and in patients taking monoamine oxidase inhibitors. Coming to varenicline, it is considered as one of the most effective medications for smoking cessation. Treatment is started with 0.5 mg once daily for first 3 days. It is then increased to 0.5 mg twice daily for next 4 days, followed by 1 mg twice daily for total duration of 12 weeks. Patients are advised to quit smoking 1 week after initiating varenicline therapy. Common side effects include agitation, insomnia, abnormal dreams, gastrointestinal upset, headache, and rarely allergic reaction. Mood changes, behavioral disturbances, and suicidal ideation have also been reported. Therefore, varenicline should be avoided in pregnant women, children, and patients with significant psychiatric illness. Close monitoring is essential during therapy. In summary, pharmacotherapy significantly improves smoking cessation success when combined with counseling and behavioral support. Selection of therapy should always be individualized based on nicotine dependence, comorbidities, contraindications, and patient preference.